wait after the end of the session if we can go over it?
Yes, at the end.
Okay, perfect. Yeah, I don't know what's going on at your end. I don't have your questions that clear. I don't know. Can you all hear me nicely?
Yes.
Okay. All right, so let's get started, and then Diego, we can so whosoever wanna wait after the end of the session, we will go over it. Okay? Yeah, don't we will clear up everything, whatever is confusing to you. Okay? All right, so let's get going, everyone. Let me put this to recording. And I brought
Recording
good
in
number of
progress.
questions so we can handle the high yields as well as we will learn together. So let's get going. You have first question on the screen. I can run the polls and let's see how you guys are doing. Of course, these polls are not graded or anything, so just, feel free to answer. Yeah, sorry, we have option E here as well on the poll, but we don't have option in the question. Gonna give it 1 minute. I don't see all of you participating. Just see, if you wanna participate, and that way you will learn the best. Okay, we are over 1 minute. I'm gonna close the poll soon now, in case you wanna answer. Gonna end the poll, share the results, and I see that multiple answers here, A and B as well. By the way, D is the right answer. Yes, Alan, this is a continuation of interactive slides. I had almost, for GI, that's how I do it. So at least, 20 questions for practicing. I feel that that's the way that everybody learns really well, and we go over the difficult and high yield concepts. Okay. All right. Yeah, so D is the right answer here. Who will be the volunteer for this one? A and B are not correct. Yes, Michael, please go ahead.
So I remember you saying in class, norepinephrine won't affect the frequency. It won't increase it or decrease it. It only affects the contraction strength, right?
Beautiful. Yeah, don't forget the slow waves, how we discussed. This is just the basic electrical rhythm on your gut muscles, right? The smooth muscle cells, I'm going to discuss it all, but I just wanted to go over the other options. So slow wave frequency will increase. That's what A option is telling you. Frequency is not going to change. Only changing is what? The magnitude of contraction by adding in ACH or the contracting neurocrines. Or if you want to relax, then norepinephrine would actually, bring the magnitude of the contraction down. So that's what is going to happen. B is out as well. Frequency will not decrease. And then C is out because it will impact, but only the magnitude. So let's take a peek. As I told you earlier, this figure is a little busy. I mean, we should. So I see in chat, so slow wave frequency. See, the slow waves are started by interstitial cells of Cajal. Just like, you know, how SA nodal fibers, they were starting the heartbeat, right? By funny currents. Those fibers will have funny currents that would pick up the threshold, and then calcium channels will pick up from there to shoot the action potentials above that. It's very similar to that. So yeah, it's just a wave. It's a wave of undulating movements, which is actually going over your gut muscles and started by these interstitial cells of Cajal in the myenteric plexus. And I'll show you a figure in a second, but just keep in mind how we were talking there in SA nodal fibers. So these are pacemakers of your gut, interstitial cells. These are pacemakers of your gut, like how SA node. So on the slide, you will see I put it just for you to remind the SA node. So keep that in mind. These cells, they will have the sodium entry, and so slight change, right? Only 5 to 15 millivolts that you're going to see going up and down. And now, up above these waves, that's when stretch is happening or ACH is being released, and that's when the depolarizations will happen. And they will sometimes happen in bundles, and that's where the contraction will be coming after these depolarizations when they have happened. Okay. In case norepinephrine or sympathetics are being released, they will bring the resting membrane potential down. So it will be hard to bring an action potential on such a membrane. So that's where your gut is actually slow. In any emergency situation, how your gut is not making as much movement, right? So that's what is happening during that time. Now, your smooth muscle cells, they're like a syncytium. Basically, they're not like the membranes which are really separating these cells. So when this wave is moving, they act like unitary smooth muscle cells. And once interstitial cells have started that, the voltage change, that would just, move up above on the smooth muscle cells. Other thing was that calcium inward current is basically causing these action potentials that you are seeing, or the depolarization changes that are happening. And again, potassium, as usual, will do the repolarization, how we have learned earlier. Just keep that in mind. Small things that you may want to keep in mind. I have put these figures up for you just for the comparison. So this is the first one that you see is the neuronal action potential. Look at the milliseconds, how fast this action potential is compared to the slow waves. So riding up above on these slow waves are your depolarizations that are happening up there. Okay. And compared to ventricular myofiber here, this takes few seconds to complete. This action potential is really strong to give you a strong contraction from the heart. So keep that in mind. The frequency number is standard for stomach, for duodenum, and then ileum. And frequency is not affected. I'm saying it again, only the contraction strength will be changing. Okay? Is everyone clear, or do we have questions here? We're good. Okay. Seems like we are good. Yeah, so yes, sympathetics will bring the resting membrane potential slightly down, so it will be hard to have the action potential going up there. Okay, here you see that figure that I had shown you in class as well. So if you go over this, you have these different layers, and right here is your myenteric plexus, and here are your interstitial cells of Cajal. They are basically synapting both ways. One side is making synapses to the circular muscle cells, and here other side to the longitudinal muscles. So when this potential is set on the membranes, it's basically impacting the muscle activity whenever there is ACH, or the contraction of the layers will take place under the action, since they are close, sitting to both muscle layers. That's how the whole activity of gut will be impacted. You can see here, this is a much better figure, the gut cross section, right? Okay, all right. So I have made a slide for you guys to make a challenge for yourself. So just know over the weekend, please go over what is Vigatomy, how does it impact, which are the actions as far as the HCl secretion is concerned, how do you affect by doing the vagus nerve removal from stomach? Then what is receptive relaxation? Can anyone tell me? What is receptive relaxation? It's a vagal reflex. Any volunteer for this? Yes, Erin, please go ahead.
Is it when your stomach like distends because of like a food bolus, it'll cause it to relax so that it can go down?
Beautiful, beautiful. So when your bolus passes through LES, the lower esophageal sphincter, and as it's passing into the stomach, at that point of time, you have VIP release, which is basically causing the stomach to relax in order to accommodate the food which is upcoming now, right? So the distension of the stomach, definitely it's sensed by the mechanoreceptors, so we call it vagal reflex. Just keep that in mind. In any scenario, if VIP is not being released, or you are removing the vagus nerve, you will impact the receptive relaxation process as well. Does that make sense? Yes? Okay. All right, great. What are MMCs? Which is the hormone or candidate hormone that's causing it? I want to see whether you have done your homework or not.
Motilin, which causes contraction of the stomach when the stomach is empty.
Beautiful. Thank you, Carla. So basically motilin will be causing these migrating myoelectric complexes. As we discussed before, this is interdigestive state when the stomach is empty. So what is the function of motilin by causing these complexes? What does motilin do?
Hi, Dr. Kaur. I
Hi,
think
ma'am.
motilin happens in between meals, and it's supposed to just cause the contraction, kind of like Dr. Fisher called it, like housekeeping,
Yes.
where like it kind of refreshes the GI cells,
Yeah.
and so in between meals, that'll
Yeah.
contract, the GI cells will be cleaned out, and it's interrupted every time you eat. I
Yeah,
hope that
it's
answers
like
the question.
clearing up. Yeah, thank you. Clearing up the remnants of food that are sitting there. So that's why we call it housekeeping, basically. Any food which is sitting there in between the meal stages. So yeah, that will be cleared up. So as we just discussed, your slow waves, basic electrical rhythm, origin, frequency, you need to know that for exam. So just, be on it. We're going to discuss about peristaltic movement just in few slides. I have question coming up and the next one as well, the retropulsion segmentation. So I'm not going to ask question for that for now. Yeah, the hormone secretions we'll discuss as well because we just did them yesterday. So I just still want to give them some time. So make sure that you finish Zollinger-Ellison. It's going to be very important for exam. The testing, how would you know that the patient is having Zollinger-Ellison syndrome? What kind of testing you want to give your patient? Gallstones, how do they impact effect of CCK on gallbladder, right? So all that stuff. Okay, next question. And let's run the poll. Can you please
Jessica, your
mute?
microphone is.
Yeah, thank you. So read the question well. Don't just rush to answer.
Sure, that was back in the 1980s. As a living member of the year 2025.
Everyone, please mute yourselves. All right, we're going to give it 1 minute. Okay, 5, 4, 3, 2, 1. I'm going to stop the poll. Okay, we have a very divided poll here, but still guessed by most of you. A is the right answer here. Who's the volunteer here who can tell us like why other options are incorrect? Yes, Diego, please take it.
The failure to relax will just mean that food cannot get in, not necessarily. The patient's problem is probably gastric reflux. So the issue is that the sphincter is not contracted, which would mean that there is less tonality, which is the opposite to B, yes.
Beautiful. So yeah, so decrease in LES tone. We relate tone to like how toned the muscle is or how nicely it is contracting, right? So the muscle has to contract at the lower esophageal sphincter in order to for this patient not having GERD. So he's having symptoms for GERD, right? That's gastroesophageal reflux disease, right? Where acid is coming up into the esophagus and it's causing pain. Let's take a look at the stem first. So patient is overweight, right? And then there is choking that is happening. He's complaining for chest pain, chest discomfort for past few months, right? The pain is getting worse after large meals. So all the causative agents are there. Just make sure that you are looking at the stem very closely when attempting this question for exam in case. So there is alcohol there is spicy food there, coffee there, and then the pain is relieved by acid inhibitors. So you have all the results. And then EKG and spirometry, you got to make sure for your patient, since they are complaining chest discomfort, you need to run EKG on them. And then you want to also have spirometry results, which came out normal and patient is relieved by the acid inhibitors. But all the causative agents are there, which can cause GERD here. Very common finding, and that's how it may look like some cardiac symptoms at times. Just keep that in mind. So definitely, alcohol actually relaxes the LES. So every time someone drinks or over drinks, they'll have the feeling of GERD in the morning, just because the sphincter is relaxing and you have acid coming up, and spicy food, of course, and coffee also relaxes. So chocolate, coffee, smoking, all these are causative agents to relax the sphincter, and that's how they cause GERD basically. Failure of LES to relax, what that condition be? Anyone? If they are not able to relax the sphincter.
Achalasia, achalasia.
Achalasia, very nice. So achalasia is another condition where LES is not relaxing at all. So what will happen? The food bolus is coming up here and not able to. So every time sphincter has to open so food can go underneath, right? The receptor relaxation has to take place in the oroid region of stomach, right? So, but that is not happening. Food is sitting up here. So that will lead to the tapering of that last end of esophageal, the whole esophageal tube is tapering at the end or dilating, right? So here the sphincter is tightly closed and this will be termed as achalasia, right? So patient is not able to have a proper primary peristaltic movements, like nice movements which will push the bolus down, that will be impaired as well, right? So that we call that term as achalasia. Increase in upper esophageal sphincter tone. Does that impact all the symptoms that this patient is seeing? No, right? Upper esophageal sphincter is up here. So once you have swallowed the food, you won't see such conditions, what you're seeing here. Inhibition of gastric emptying. How do you think that is related to this? Actually, if you slow down the gastric emptying, it may bring some of these symptoms back, but not as worse as we are seeing here in this scenario where you've been given all the causative agents there, the alcohol, the spicy food and everything. And they may lead to more acid, and then they may lead for those gastric contents leaving the stomach slowly. Remember, all those things, they have an impact how the gastric emptying will be done. If you have more acid, it's going to be brought into the duodenal area very slowly if there are more acidic contents there. Yes, Diego.
The gastric emptying would also be the domain of VIP, correct? So BIP will control upper and lower esophageal. I'm sorry, lower esophageal and the duodenum.
Say it again, Diego. VIP is basically for the relaxation of the LES. So what are you saying?
If VIP was also involved in gastric emptying.
Not really. No, VIP is not involved. These are mainly CCK, GIP has a role, then GLP has some role, and secretin also has some role there. Okay. VIP is more of a relaxation up there. Okay. All right. So yeah, inhibition of primary esophageal peristalsis, as I mentioned earlier, if your LES is not relaxing well, then you have impairment of the peristalsis there, right? Is everyone clear of all these things that we are talking? Are you good? All right, wonderful. Okay, sorry, I should have brought the cues earlier. Forgot to move my slide further. So here, let's take a peek. So if you look into this figure right here, as your bolus is passing through upper esophageal sphincter, it's going down. And as soon as this process starts, from the swallowing, you still have this voluntary, control over this, like sending your bolus in. And once you have sent it through this, from this area on, this is going to be all under vagal reflex, basically involuntary, right? So oral phase is voluntary, but pharyngeal and esophageal phases are reflexive. And then your receptive relaxation starts here. So VIP and NO, they help relaxing this LES and also causing the receptive relaxation of the stomach in order to accommodate the bolus which is coming down. And so that's how it will be working. Yeah, how we discussed, like if there is achalasia or LES issues, If it's not relaxing well, that will impair the peristalsis and will cause patient dysphagia, actually, because the bolus is not going down really well. Okay. What is Amir saying? I didn't get the point. Amir, you want to say? I have to read the chat. So because the LES fails to contract, it causes, yes, exactly. So because, yeah, okay. All right, you got the point, right, Amir? Are we good? Okay. All right, so let's move forward. Yeah, this is just a figure explaining you the peristaltic movements. There is always air pressure which is moving behind the bolus and pushing the bolus down. This is basically the primary peristalsis that we are talking here. You know how, so let's say if you are getting the toothpaste out of the toothpaste tube, how you are slowly pressing from behind, that's how the pressure, the area of pressure which is created behind the bolus, it's going to push your bolus down and down, and partly because of the gravity too, but there is a pressure maintenance after swallowing that will go until the food bolus reaches down here to LES, and you know, when the bolus comes down, the air is also relieved here. Okay. All right, next question. Should be easy. I can just go by your hand raising. We just discussed it. Anyone? No volunteer for this? Yes, E is the right answer. Yes, Christian, please go ahead.
This is just kind of like what we said before, how like we even said it in class, every 90 minutes, like modal, and it's almost like a housekeeping thing where it just like contracts and like gets rid of any bacteria that's just like building up.
Yes. All right. I think everyone is clear by now. What are mass movements? Rest of the options, if I ask.
It's when the colon has to move things from one of its segments forward.
Yeah. So basically just keep in mind by the time the undigested, oh, not undigested, I mean the leftover food, after the digestion, leftover food reaches the colon area or the whole large intestine, basically. So by the time the water absorption is all done and the fecal matter is left with a very little water there. So it becomes very, very hard for the gut to move these contents further down to the rectal area. So body will be having like 1 to 3 times a day. These are called mass movements. That's like strong contractions in large intestine to push that fecal matter down towards the rectal area. So it will be happening 1 to 3 times a day to push that solid fecal matter down. Okay. All right. What if we don't have MMC? MMC is present. If they are absent, what will happen? If there are no MMCs caused by, bacteria will build up. There will be infections in the gut, right? Because leftover food will be just sitting there in the corners. All right. Again, the challenge yourself slide. Just make sure that you don't miss any point. These are going to be very, very important stuff that I have lined up here. Okay. All right. Now, tell me the differences between peristaltic movements and segmentation. We just discussed about the mass movements, right? Anyone who can explain? Yes, Diego.
Peristaltic is the forward motion. It's where the longitudinal muscle, and it basically contracts. And segmentation is the circular muscle that pinches in. So yeah, so it's a combination of pinch in and then longitudinal contracts and then it relaxes and that's how things move first like forward.
Yeah, very nice. Thank you. So basically, in case of peristalsis, the circular muscles are contracting behind the bolus. Just keep in mind. And on the sides of the bolus, the longitudinal muscles will be relaxing that time. So you have to have on the sides proper neurocrines released, which will cause the relaxation in the inhibitory pathways in effect here in the longitudinal muscles. Circular muscles will be contracting, so you need ACH or something which will be contracting behind. Whereas your segmentation is just the circular muscles. It's basically peristalsis is pushing your bolus down the gut. Segmentation is mixing up the two boluses. So circular muscles will be contracting. As you can see, this is a light bolus, this is dark, right? So segmentation is basically pinching the circular muscles in between. So half of this bolus is mixing with the other bolus and half of this bolus is mixing with the other bolus, right? This is done because so your chyme can nicely mix up with the gastric juices that are being released here in the intestinal area. And enzymes can work on these really well. So that's the function of segmentation. Mixing nicely and mechanical digestion as well, plus let enzymes work really well. So only circular muscles in case of segmentation, but both the muscles, longitudinal and circular in case of peristaltic movements. Diego, I still have to post them. These will be posted tonight after you, because I had few more questions that I wanted to finish. That's why I didn't post them yet. Okay, which is the main hormone that will impact the gastric emptying? Which has most potent control on gastric emptying? CCK, very nice. And other hormones, as we discussed, GIP also has a role. GLP, we discussed, right? Secretin also slows down the gastric emptying a little bit. What is retropulsion? I have a question coming up, but just in case if you have read it. No, Michael, it's not vomiting. Retropulsion. Yes, Alicia?
Is it repeated mixing of the chyme in the stomach before it enters the pylorus?
You are close, but not exact. Anyone else? Sending bolus back to the stomach. Very nice, Jay. Yes. So when bolus is or the chyme is being brought into the intestinal area or the duodenal area, if the mechanoreceptors feel that it has not been grind really well, and these are like bigger chunks than what it's supposed to be, it is actually pushed back into the stomach, and that process is called retropulsion. Okay, so that will happen in case the grinding hasn't been done properly. So it will, yeah. I mean, ideally, it will slow down the gastric emptying later on, but once the bolus has to be pushed back, to be worked on more. Okay. Okay, next question. Any volunteer? I think I won't run the poll because we want to do more questions. Yes, Christian.
It's B.
Not really. Alicia?
Is it D?
No. It's close. You guys are close, but I'll tell you why. Yes, Andrew?
Oh, thank you, doctor. Would it be A?
Yeah. No, it's not A. Sorry.
Okay.
It's not C, Alan. Finally, it's B. I mean, I said all no to all other options, right? So it is B. It's gastrocolic. Now, can anyone tell me why? Yes, Diego. Yes, Alicia. Why it's B?
After rereading it, I realized it says when the stomach is stretched. So that's the gastrocolic reflex. Rectosphincteric would be lower down.
Beautiful, beautiful. And when stomach is stretched, and that's where it starts, we call it gastrocolic. Um, you can relate this to the babies, like as soon as they finish drinking milk, and sometimes they'll be ready to go potty, right? So that's gastrocolic. So distension of the stomach, if it's causing the rectum to contract or the intestine to contract further, that's what we call. Oh, many of us, we have to have like coffee in the morning or tea in the morning to go to the bathroom, right? To clear ourselves. So that's a kind of gastrocolic reflex. Is everyone understanding this? So sometimes, you got to initiate the mass movements, or go to the bathroom. You want to have some tea or coffee to clear ourselves up, right? Yes, it could be, but you have to put something in the stomach to get it going, Ellen, right? Stomach and colon. Very nice. Good. Okay, yeah, that's what it is basically. So if you say duodenocolic, as the name is suggesting, things which are happening in the duodenum, which are causing colon to relax or to contract, that will be duodenocolic reflex. Intestinal, the same thing. Rectosphincteric is a little bit different. So it's basically what happens when the rectal area is getting filled up almost 25% with the fecal matter. There is a reflex on the internal anal sphincter that there is urge to defecate that time. I mean, it's still under the voluntary control because external sphincter is under your control, but there is an urge just because if rectum is filled up with 25% with the fecal matter, the relaxation of internal anal sphincter will take place, but your external sphincter will be still contracted, right? Yeah, Michelle, we're going to talk about the rostra as well. Just in few minutes, I have question coming up. Michelle had the question in chat, so give me another minute or so. Okay. All right. Next question. Any volunteer for this? So partially, Diego, this will answer your question, what you were asking.
Yes, partially.
Yes. We'll take care of the rest as we finish. Yeah, I'm seeing option answers in the chat. Any volunteer? Yes, Christian, please go ahead.
So GIP, the big takeaway is that it's oral glucose, which
Yeah.
would signal like GIP to be released, which induces insulin release.
Beautiful. Yeah, just keep in mind, we will go over insulin in good detail and how does it talk to your IV glucose. Glucose is actually a sensor for insulin. So, whenever there is more glucose present and insulin is going to come into action, and how the absorption is going to take the further, picking that glucose and putting it into the cells and all that stuff, how the transporters would work under insulin. We'll talk about that more in spring under endocrine stuff. But for now, just keep in mind any glucose which is sitting in blood, that's where your insulin will come into action, right? Because glucose is a sensor, as I told you, for insulin secretion. Here, oral glucose, as soon as it goes into your mouth, that's where your GIP is going to get released out, which is going to ask for those beta cells to get you insulin as an incretin. So keep that in mind. Okay. All right, very nice. I think we are doing well. These are all important questions. Just keep in mind, and that's why I brought them up. I thought we will revise them and refresh our memories what we had discussed earlier this week. Okay, Thanksgiving dinner, lot of food, as we all do. So what do you think is happening? Yes, Diego.
Today, because of the stretching, will be the more immediate signaling, and then gastrin takes over from there.
No, that's incorrect. Anyone else? Read it really well. C is incorrect as well. Michael said E. Chris, E. Yes. E is the right answer. Now you have to tell me why did you pick E? Chris, would you like to describe it, please?
Yeah, sure. So VIP is going to open up sphincters. Dr. Fisher was saying that VIP is very important people. They open up doors, and that helps me remember that. And then acetylcholine is going to help to kind of do the rest and digest and activate the gastrointestinal system. And then gastrin, I might need help with that one.
Yeah, gastrin is for your acid release, right? So gastrin
perfect.
and whenever you're pushing so much food in there, it's going to cause distension anyways, apart from your parasympathetic system action. Yeah, but why A is out?
A is out because chemoreceptors wouldn't sense stretch. That'd be mechanoreceptors.
You got to read the options nicely in exam. I'm telling you, please don't jump for the answers. You got to yes. Thank you, Chris. Why B is wrong?
Norepinephrine would decrease muscle contraction, right?
Very nice. Beautiful. Beautiful. Thank you, Michael. And C is incorrect. Why? So far, whatever we have discussed, it was a summary kind of. So I brought this question later today. Yes, Christian.
Because it says it increases like the frequency of contraction.
Yeah.
By the parasympathetic nervous system, so that's not correct.
Yeah, frequency never changes. It's only the magnitude of the contraction, okay? If I give you magnitude or the force of contraction, that would be the right answer. Why D is incorrect?
Because it's the longitudinal and circular muscles, like the muscularis externa.
Beautiful. Yeah, the mucosa is just for your secretions, right? That's the internal part of the stomach. That's not responsible for motility. Beautiful, Erin. Thank you so much. We all made it. So yeah, just keep an eye on the options that we are giving in the exam. Please, I'm telling you again and again. Okay. All right. So now we are back to Michelle's question. Which one is the most frequent movement in descending colon? Yes, Michelle, you are correct. A is not correct. Who wrote that? Alicia, I'm sorry. Andrew, D is not correct either. Yes, C is the right answer. And Michelle, you are absolutely right. The frequency would change in a condition like IBS. Yes, definitely. So the mass movements will also be more. Hostration is going to be more. Can anyone explain us hostrations? We know now retropulsion, we know peristalsis now, we know the mass movements only happening 1 to 3 times a day, right? What about hostrations? Anyone? What's the frequency? Who will explain? No? So Hostra, have you done that in anatomy? Hostra, have you seen those?
Not yet.
Not yet. So you will be seeing probably in the coming week. So these are sac-like or pouch-like formations in the later part of the colon, right? So those sac-like pouches there, we call them hostra. And it's basically very slow segmentation of the fecal matter back and forth. Just like how we were doing segmentation earlier in small intestine, is the same thing. It's mixing of the fecal matter to get it a final shape or final form, right? But it's hard, like semi-solid by that time. So it's hard to move. That's why you see those pouch-like formations at that part of the colon. But they occur every 30 minutes and they last about 1 minute. So that's going to be the most frequent. So hostra does not refer to the structure, but the action, I mean both. Both. Hostra is basically those pouches or sac-like stuff that you see. So yeah. Peristalsis is more when the food is starting, but in between also you'll see here and there some peristaltic movements happening, but it mostly meals related and when bolus is moving all across the gut. Chris? Okay. All right, so let's move forward. Next question. By now, you should know it. So just raise your hands if you're ready. Yes, Michael, please go ahead.
It would be D, right?
It would be D, very nice. So it's towards the pylorus, right? So if there is a problem at that portion of the stomach, or the surgery happened, there will be some time that, the surgical procedure, after the surgical procedure, a patient needs, and retropulsion will be affected. Very good. Very nice. Segmentation anyway is happening in the intestinal area, and receptive relaxation is up in the orid region. So yeah. I made these questions just kind of, so you understand what movements are we talking and where do they happen. That's all basically. So next question. D is not the right answer. A is right. Now, who will explain us why A is the right answer? Antonio, do you want to take it? Or anybody else? Yes, Andrew, please go ahead.
Oh, sure, thank you. Well, I think the pizza would be last because it has the most fat in it, so that's going to basically be broken down. It's got to be broken down into like small droplets. The Coke is going to basically be liquid sugar, so that's going to be easily transported out. And then the brownie is still sugar, but it's solid, so it needs a little more time.
Yeah, be ready for the exam for the order. Which order the food will be quickly emptying out. So gastric emptying is mainly depending upon fats and hydrogen ions. We discussed that more fats is there, more hydrogen ions are there. It's going to be slow down, right? So first of all, liquids will move, and then solids will stay longer, and osmolarity plays a role as well. The normal osmolarity will go much faster than hyper. Okay. All right, great. Next question. Okay, is anyone ready? Is it too hard? We went over this yesterday, slightly, not completely, but still. Okay. Who's giving me the answer? Oh, very nice. Joy, yes. Satvika, Ronak. Yes, D is the right answer. Would you like to explain, please?
So is it because CCK will act on the pancreas to release secretions? And I think also
CCK will act on
the pancreas.
What's direct action of CCK on acinar cells?
Oh. Okay. Yeah. I'm not sure. Sorry.
It's okay. That's fine. Thank you. Thank you for, breaking the hesitation. I'm happy everyone wants to answer. Anyone else?
Is it because it relaxes the sphincter of body, which will allow for the bile to go out?
No, that's for bile. Gallbladder is for bile. I'm talking about the acinar and ductal cells. So listen, CCK talks to the acinar cells to get to the pancreatic enzymes. But another role of CCK is to potentiate the action of secretin. So yes, parasympathetic stimulation will also make secretin to work on the ductal cells to get you pancreatic secretion. That's the role of secretin, to give you pancreatic secretion. But CCK does potentiate the action of secretin to get you the secretion. So just keep in mind, it's indirect, but it's there. Okay, it potentiates the role of secretin. All right. Yeah, these are very small or minute details, but you should be ready. We did this question already, but I just wanted to go over it again just because of the, importance for boards, and it's very high yield. So what's the answer? Yes, C is the right answer. Potentiate means it increases. Who's this? Yes, Jillian. So potentiate means it increases the role of secretin. Yeah. So yes, C is the right answer. Where did you pick the Q in the stem? Any Q from the stem that you picked?
When it says that it has antral mucosal arrhythmia, but no ulcers and masses, that tells me that there is damage to the mucosal layer. Therefore, it's probably a pylori infection.
Beautiful. So basically, Zollinger is out because we don't see gastric hypertrophy, right? That would happen under gastrinoma because there's tons of gastrin that is being produced by the tumor, right? So if you're looking at a stem which is telling you there is hypertrophy of the mucosa, just, be wary of these things for exam. That's why I brought this question up again, because it's very, very important topic for boards and exam. So if you see antral area having the redness or erythema, as I mentioned earlier, but no mass there, that's a good indicator of H. pylori, which is very common, and it's actually correlating. I'm forgetting the exact percentage to the gastric tumors of H. pylori if it's left untreated, but it's more than 90%. So just, be wary of it. So what will happen in H. pylori infection to the gastrin levels? Of course, they are not as high as Zollinger, but what will happen and why? Yeah, gastrin will increase. Why? Anyone?
Is it because the H. pylori is gonna produce the urease enzyme, which is
Which enzyme?
Urease.
Very nice. Yeah. So that how does it inhabit there?
So that's going to make it more basic, and make the stomach think that it needs to be more acidic.
No. So just let's clear this up. So basically this bacteria has an enzyme urease. So that's an advantage to this bacteria. So basically it colonizes towards the antral end, right? Right here, if you look at the figure. So how does it inhabit? Because that enzyme is converting urea to ammonia right here. So all those acidic environment which will kill other pathogens, this bacteria will still survive because this has that alkaline environment here, right? So it helps colonizing these bacteria towards the antral side. Now, one thing that the antral colonization for these bacteria, they are also inhibiting somatostatin secretion. Remember, I told you yesterday. So somatostatin is there to take care of when the gastrin levels are high, or the acidic environment is really high, somatostatin will automatically act on G cells to snub the gastrin secretion, right? Now you don't have that regulation anymore present there because bacteria are not letting somatostatin secretion take place because of the antral colonization, right? So overwhelming HCl is sitting there. They are also making ammoniamides, which are very detrimental to the mucosal skin. They're going to make cracks in the skin and also interfere with the mitochondrial function. So through the cracks, the HCl is seeping down into the gastric lower air layers, right? So these layers are all cut, damaged. Now your chemoreceptors, they are thinking there are not enough HCl because it's seeping down through these cracks. So they're gonna produce more gastrin basically because chemoreceptors think that there is not enough acid there, right? So there is even more gastrin levels and that will bring you more acid and so forth. It's a vicious circle, not easy to break, right? So H. pylori infection can be very detrimental that way. And moreover, the duodenal ulcers will take place because right here it's sitting in the antral area. So more acid is eventually going to flow down here and it's going to cause damage to the duodenal area. Clear? Everyone clear regarding this? Now, can anyone tell me what is happening in Zollinger-Ellison? And how would you know your patient has Zollinger-Ellison? What kind of testing would you give them and why? Anyone? We discussed it twice. Secretin stimulation test. Why? Yeah, gastrin levels are high because they're coming out of the tumor, right? No feedback inhibition, but what does secretin do? What's the role of secretin? So if you give, so first of all, you want to take a baseline. Yes, Abram, please go.
Yes, ma'am. So, from the S cells, secretin is released and it's supposed to increase the bicarb from the pancreas and decrease the hydrogens. So that's why you want to try that test. And if the patient with Ziegler-Ellison syndrome, their pH doesn't increase, then you know because of the test. They'll have a low pH constantly because the bicarb didn't work.
Well, so basically it works by snubbing down the gastrin release, right? Secretin, whenever duodenal chemoreceptors are sensing that there are more hydrogen ions coming into the duodenum, and that's when secretin will jump into action because that's the major stimulus for the secretin release, right? In order to get you more bicarb, and yes, part of your answers is correct. So it's gonna mix up those contents and neutralize those contents, right? To a optimum pH so enzymes can work really well in the duodenal area. Now, in this scenario, since it's a tumor and it's consistently releasing gastrin, tons of gastrin, so there is high acidic content. Ideally, if you give a patient secretin through IV, it should snub the gastrin release. But in this scenario, that's not going to happen. So that will be a good testing to see whether you can snub gastrin release. If patient just has some other peptic ulcer disease, not the Zollinger-Ellison, you can see that through secretin stimulation. But as I said earlier, imaging these days is a good confirmation test also on the side, right? You have to do imaging anyways. Yeah. Is everyone clear for this one? Gonna be very important for exam, both H. pylori and this one. Okay. All good? Are we doing good so far? Any questions? Okay. All right. Why do you think in case of cystic fibrosis, the ducts will be clogging? The pancreatic ducts will be clogging. Excess mucus, yes, why? And why the digestion is not so good in case of cystic fibrosis patients. Very nice, Alicia. Would you like to, yes, EFTR doesn't work, right? So one more time, I'm just gonna bring it up and we will actually finish this week because I'm gonna talk about chronic pancreatitis and all that stuff with digestion and absorption this week. Yeah, Michelle, I'll come to that after this, once we finish the session. If you can stay back, I can answer your question. So here, listen everyone. So CCK is talking to the acinar cells to get you the enzymes, right? And here is secretin, which acts on the ductal cells to give you the fluid, the bicarb or the watery portion of it, of your pancreatic juice. So they both work. And I told you the CCK even potentiate the effects of secretin. So while all this is happening, if you look at this ductal cell here, and that's where I had made a correction, which is not there in the book. So just keep that in mind. Here you have the flipped figure as opposed to what we were looking in the parietal cell. So you were consistently releasing hydrogen ions into the lumen of the stomach in case of parietal cells, right? But here in the ductal cell, this thing is reversed now. Now hydrogen ions, they are being released into the blood, and bicarb is being poured out into the lumen of the ductal cells here, the pancreatic ducts, right? So now this has to be very aqueous, very watery. So what will happen when you are releasing bicarb here? There is this CFTR channel which actually pours chloride out into the lumen, right? So what is happening when you are making a negative potential here in the lumen by throwing this negative charge here? Sodium is just going to follow through the paracellular routes, and then water is going to follow the sodium. And that's how you make these secretions very aqueous. But in case of cystic fibrosis, you don't have this channel working, right? So there is not enough buildup of chloride here in the lumen. And then sodium is not falling or water is not falling. So these secretions will be very mucousy, very sticky. And that's what the problem. So the ducts, in case of cystic fibrosis, they'll be clogged by all these mucousy secretions. Make sense? Everyone got it? Okay, there are a few things in the chat. Let me go over. Michelle, I'll come back to you. Yeah, mucus prevents the enzymes from, yes, definitely. So secretions are not entering nicely into the intestine, so enzymes can't work and do a good digestion there. Yeah, yes, very nice. Okay. Thomas, what was your question? Yeah, results in no water transport. Yes, beautiful. Okay, as long as everyone got it, we're gonna repeat all this when we are talking about digestion and absorption this coming week, and I will wrap it up nicely. We will go over chronic pancreatitis, all other pancreatic conditions we will discuss in coming week. And then we're gonna discuss other digestive or absorbing disorders, whether it's bile or liver problems or all that stuff. So every pathophysiology will be wrapped up in the coming week. Any further questions up to this slide? Are we good? Okay. All right. Oh, this is the figure I wanted to tell you guys. Yeah, I thought I already included in the last slide, but this is the figure. So just be wary, as I told you, whenever there is parasympathetic stimulation, whenever there is more flow rate, bicarb is going to be the main ion in your secretions, whether it's coming from saliva or it's coming from the pancreatic ductal cells, right? So there is no contact time story here, basically. More flow rate, more bicarb. That's all. That's how you should remember this. But anyways, you should know whether it's gastric secretion, whether it's pancreatic secretion or salivary secretion, the final composition of the fluid. That will be important for as far as the exam is concerned. Okay, keep that in mind. So here, just wanted to tell you these are your I cells, which are giving you CCK. They're talking to your SNR cells under IP3 calcium pathway. Of course, parasympathetic stimulation has to be there to give you any pancreatic secretion, right? And it's going to give you the enzymes. But here, if you see, the secretin works under ACH, but CCK is potentiating that effect on the ductal cells, okay, to give you the aqueous secretion with filled up with bicarb here. So yeah. That was the last question about. Now, another important question as far as the exam is concerned. So let's say if we remove the vagus nerve here in this figure, which phase you think you can remove as far as the famous two phases are concerned for your gastric secretions? Okay. Yeah, the cephalic phase will be gone, or the beginning of the gastric phase as well, where the vagus stimulation is concerned, right? So if you perform vagus nerve removal from the stomach in your patient, are they still making acid? Yes. How? Why? Yeah, distension triggers gastrin, very nice, in the antral area, right? And the presence of food. So keep that in mind. I just put this block for you so that can tell you if you perform vagotomy on your patient, you are still giving them release of acid through distension of the antrum and the presence of food that they are eating that can bring them the gastrin release. So gastrin is going to talk to the parietal cells, and also gastrin talks to which other cells to give you more acid? Anyone? So there are two roles for gastrin, right? Talking to parietal cells, yes, Jasmine, very nice. It's also talking to the ECL cells here in the circulation, right? So ECL cells are sitting close to this vicinity, right? So they're gonna also release histamine and talk to the parietal cells to give you more HCl. Clear? Everyone is clear about all these mechanisms? Ready? I'm gonna make you ready for exam actually. By the time we finish all the contents, you should be good to go. All right, next question. Everyone clear about all the different pathways, how the acid is being released, how your parietal cell have different receptors which are talking to different entities to get you more acid, right? So the final why PPIs are so game changing is because they're gonna close the main entry door. So someone with acid reflux, they'll have the best relief by blocking the main door. So you want to give them the PPIs, and that's how the major help you can give your patient, right? Do you think so another correction that I made, this book, this figure is again from the book. It's missing the GRP here, which is talking to G cells to give you gastrin. So I just added that. Make sure that you remember that. Why you think if you are giving your patient atropine, you're still making gastrin release happen? Beautiful. Yes, Andrew. Very nice. We didn't cut off the GRP pathway. Remember, atropine is only going to talk to M3 receptors, right? The postsynaptic release. That's where atropine goes and binds. But GRP is talking to its GRP receptors on G cells, right? So here your atropine is not going to work, even though it's under vagus control, but GRP has its own actions on G cells and give you gastrin. So if you look this figure, if I block this pathway, you are still having gastrin into action by vagus GRP pathway, by antral distension, by presence of food, gastrin will still be there. So if you give your patient histamine blocker, you still have you know, gastrin release and parasympathetic stimulation to give you acid. So your histamine blockers, they're going to be mild, you know, acid influencers. Everyone is clear about the whole pathway? Yes? How do you think the prostaglandins help your stomach lining? Yeah, GI protein, but what do they do? What's the action on stomach lining? They do vasodilation, very nice. So they increase the blood flow in the area to remove the toxins and hydrogen ions around, right? They inhibit ECL cells, beautiful. Yeah, they decrease gastrin secretion. Okay, what else? They make bicarb. They actually increase the bicarb secretion and wash off or make a lining on the epithelial cells in there, right? So just keep that in mind as a vasodilator, inhibition of ECL cells. So all this. So if your patient is taking more Advil or ibuprofen, they're basically killing the prostaglandins, and you know that's a good thing to remember. Yeah. I was talking to my son the other day, and he's telling me, so he's a resident, by the way, but he's very, you know, insightful things sometimes to add. So he's telling me, just adding my experience here. So for my knee, I was trying to take ibuprofen, and he's telling me, I will take a biscuit or something like before I eat Advil, just like how we all do, not taking it empty stomach, so it will harm the lining more. But he was telling me otherwise. He's like, Mom, just take it without the biscuit. I think when you add biscuit in there, you're gonna start your acid secretion already, and then your Advil is more detrimental. So I don't know. I mean, he's probably read some paper or something. He was telling me, so take it just empty stomach. I won't advise any one of you, just telling you my experience. I mean, sometimes, you know, you get to listen to what's coming out in the papers these days. Oh, Antonia is telling me the same thing. Yeah, I think he read a few papers, and that's where he was telling me, it's like, take it empty stomach quickly without eating. Otherwise, you will start your acid release when you're taking Advil. So it's going to make it worse. Yeah. Okay. All right. I think we have covered a lot of things. I will probably, I'm going to stop with this question, and then we will continue for the final week. I will bring back the second week questions more because they'll make more relevance as far as the pancreatic effect on digestion and absorption is concerned, and the bile effect. So we will sum it up in this coming week, but with this last question of the day today. So we have this woman, she had cancer and they removed the distal ileum. And she's now given B12 injections to avoid pernicious anemia. Which of the following conditions is also very likely she's going to experience? Any volunteer? Okay, Ronak is answering already. Anyone else? Ronak, can you answer? No, answer is correct. Ronak is right. But you got to explain me all the options. Very nice. Thomas is telling us something because distal ileum functions in B12 absorption. Beautiful. So that's why they are taking B12 injections. Distal ileum, by the way, that's the place where your absorption is going to take place. And as I said, I wasn't going too much into this question because it's dealing with the absorption, which we haven't started yet. But at least, you know, some initiating stimulus I wanted to bring. So this weekend, you should sit down and start reading or watching the videos for digestion absorption, so we can sum up really nicely what we have learned this week and then coming week. So yes, let me explain it. I know we didn't talk about it, but the bile juice, as I was telling you, how important your pancreatic enzymes or your bicarb is in order to take care of your fats, right? They were so important. So any pancreatic problem can bring an impact on your fats digestion or absorption, right? Similar way, your bile is so important, and bile is basically acting as a detergent for the emulsification of the fats, right? So it's coming into the duodenal area, mixing up, and then pancreatic enzymes would work on the stuff. I will explain it a little bit more this coming week when we discuss further. But the bile salts, they are limited in quantity. So once they have done their job, they will be recycled back into the liver and where they are making more bile, and that's going to get stored in your gallbladder and then released further down. So it's not making bile salts every time, right? So if you had the terminal ileum cut here, what your stem is telling you, so not only it's impacting the B12 absorption, but also impacting the bile salts absorption too, right? So as I said, liver will make some, but it's not going to compensate for such a loss that is happening every time with all the digestion that we are doing daily. So patient will be losing the bile salts into the fecal matter if they don't have the terminal ileum to do the recycling of these bile salts. Okay, so that's what the whole thing is about. Does it make sense? So the patient will end up having malabsorption of fats, and the fats will be appearing in the fecal matter, and they'll have steatorrhea, as your option is telling you. So we didn't talk about, there is nothing that is mentioned in this stem regarding pancreatic insufficiency, so you can rule that out. It's not secretory diarrhea. We'll discuss what secretory diarrhea is. It's massive. That's going to come this week, so I'll talk more about it. There is nothing else wrong with the malabsorption of protein. And proteins are all done in the early part of intestine. By terminal ileum, all the proteins are already absorbed. So we are good here. And STEM didn't tell you anything about the duodenal ulcers. So we are good for that option too, right? Is everyone clear about this stuff? Yeah, but I would suggest you one thing: start working on the QBank that's there for the exam prep and see how many questions you can attempt, and rest we will finish this week, so you'll have more chance next weekend to finish the rest of the questions that are left over. We good? Yes? Michelle, I'm talking about the QBank on Canvas for this exam, for GI exam. Are you